Okay, the next chapter is disorders of esophagus in children. So the first one is esophageal atresia. Atresia means absence. So esophagus is discontinuous. It is associated with the anomalies, these things, that is tracheo-esophageal fistula and factual association, that is vertebral anomalies, imperforated anus, cardiac defects, tracheoesophageal fistula, already taught, and renal anomalies and limb anomalies. Okay, now what is esophageal atresia, that is absence? The first one is tracheoesophageal fistula, that is most common defect in mesenchymal separation between trachea and esophagus. It has classified into broadly 6 categories. The most common one is proximal esophageal atresia with distal tracheoesophageal fistula. This is the most common one, and the least common one is this one, and this is an H shaped, so type E or type H, tracheoesophageal fistula without esophageal atresia. So these are the things. Now, what is the clinical features? The most important clinical feature is recurrent vomiting, multiple episodes that leads to aspiration pneumonitis, and excessive frothy salivation is seen. Antenatal polyhydramnios, that means because the baby is unable to swallow amniotic fluid, so polyhydramnios is seen. In chest X-ray, we can see that coil nasogastric tube in proximal esophagus. If we put a nasogastric tube through the baby's nose, we can see it is coiling up in this part. Okay, so resistance is encountered during insertion of nasogastric tube, and coiling can be seen in chest X-ray. So the treatment is obviously anastomosis of the esophageal ends and division and ligation of the tracheoesophageal fistula. Okay, now let's see 2-3 questions regarding this. A full-term newborn develops frothing from the mouth, cough, and choking episodes soon after first feed. Attempts to pass nasogastric tube are unsuccessful. A chest X-ray shows nasogastric tube coiled in the upper esophageal pouch. What is the most likely diagnosis? So you can already understand that is esophageal atresia with tracheoesophageal fistula, because after all the coiling is happening here in this case, or you can think of this case because it is the most common one. Okay, now the next one is this one. So it is said that 1 day old male neonate was born via C-section due to polyhydramnios. Now unable to feed and has excessive salivation. The nasogastric tube is inserted but coils in the upper chest on X-ray. So what is this? So the last line obviously makes it sure that what investigation confirms this diagnosis. So chest X-ray with the nasogastric tube in situ is the obvious answer. Next is esophageal atresia with air in abdomen. So a neonate with suspected esophageal atresia is found to have air in the stomach on abdominal X-ray. Which type of esophageal atresia is most consistent with this? So these are the types. Isolated esophageal atresia, I can see you this. The first one is isolated esophageal atresia. Esophageal atresia with distal tracheo esophageal fistula, that is this one. Esophageal atresia with proximal tracheoesophageal fistula. Proximal fistula, this is distal fistula. This is proximal with distal tracheoesophageal fistula. This is the least common one. This is the H type of tracheoesophageal fistula and esophageal stenosis. This one, the last one. Okay. Now, what is the answer? As the answer will be the most common type, that is this one. So the answer is obviously the most common one. Okay. So these are the questions. Now let's talk about the gastroesophageal reflux disorder. Gastroesophageal reflux disorder. Let's talk about the next part, that is GERD, gastroesophageal reflex disorder. This part, gastroesophageal reflex, it is a physiological one. That means it is a normal one. So it is normal, but obviously when the disorder comes, it becomes abnormal or pathological. The age of onset is less than 6 months, so a baby of infant. What happens that due to short esophagus, recurrent vomiting is seen, so aspiration happens, that may cause aspiration pneumonitis. Same thing, aspiration pneumonitis, same as esophageal atresia. Also, this causes malnutrition, and that's why failure to thrive. The most characteristic thing of GERD is sand diaper syndrome. What is sand diaper syndrome? That is spasmodic dystonia, posturing of back muscles, that is opisthotonus. So what is this? We can see in this picture, there is a GERD. So what happens here, that this is the reflux that occurs lower esophageal sphincter. That's why multiple time of vomiting can be seen, and this is the opisthotonus that can be seen. This is the opisthotonus sand diaper syndrome, that is most characteristic of gastroesophageal reflex disorder. Now, what is the talk? So you can see this as well. This is the back muscles, they are going dystopic movement with intermittent tonic posture associated with feeding. Okay, so this is opisthotonus. Where can also see, obviously, tetanus. So neonatal tetanus and bind, that is bilirubin induced neurological damage. Now what are the investigation? The best investigation is pH multi-channel intraluminal impedance monitoring, that is multi-channel intraluminal impedance monitoring. Okay, the best method that measures the level of which reflux occurs. Otherwise, we can obviously do endoscopy. Esophageal mucosa can be seen via that, and 24-hour pH monitoring. If the pH is less than 4, indicates GERD. Okay. Now, what are the treatment and management? So, the very first one is that it usually resolves by itself by the year of 2 to 3 year of age. It resolves mostly itself. Okay, so there are some modification that can be done, that is small and frequent feeds. Okay, thicken the feeds, avoid caffeine, spicy food, chocolate, obviously, that's the thing. If there is no improvement, then we can go to pharmacological method, that is PPIs, omeprazole and lansoprazole. Duration of the treatment is 3 months to prevent the recurrence. If there is still no improvement, then this is the last one that we do not do usually, done for refractory GERD, that is Nissen fundoplication. Okay, Nissen fundoplication for GERD. Nissen fundoplication, what happens? Part of fundus is wrapped around the lower part of esophagus. So higher the lower esophageal sphincter, tone and pressure, that's why less reflex. This is a very good picture to understand the Nissen fundoplication. That is, this is the fundus. What we do, fundus is wrapped around the back of esophagus. We just take it, stretch it, wrap it around the esophagus and secure it with the sutures. Okay, for GERD. Next is foreign bodies in esophagus. The features are it happens in the age less than 3 years, because in the age of 2 3 years, children have the tendency to take every object in their mouth. Okay. So the common foreign bodies are obviously coins, nuts, small toys, everything that are dangerous. What are the dangerous foreign bodies? That are button and batteries, because they may do coagulative necrosis. Okay, in the esophagus. Multiple magnets can stick each other around the bowel loops, and obstruction and perforation can be done. And sharp objects like fish bone or toothpick, they are obviously dangerous. Now, what is the natural course? Most foreign objects will pass through and get excreted, okay, beyond the stomach. The sites of impaction, the problem where, that is cricopharynx, the first one. So this is the picture. It is the cricopharynx space. This is the first one. Then the mid esophagus at the level of tracheal bifurcation and right above ileus. Okay. Now, what are the clinical features? History of ingestion of foreign body obviously may be absent. People may not have seen this. May be asymptomatic as well. So if symptomatic, what can be seen? That he won't have feed. Okay, drooling of saliva, you won't even take the saliva inside. And chest discomfort and pointing towards discomfort. Respiratory complaints may occur. Recurrent cough, wheezing due to pressure effect on the trachea can be seen. So what is the investigation? The first one is obviously X-ray, the easiest one, because most of the things are radio opaque. If the thing is not radio opaque, then contrast study of esophagus and esophagogram is good one. What is the management at the end? The blunt objects and asymptomatic observed for 24 hours. Okay. Indications for removal of by esophagoscopy is symptomatic. If it is symptomatic, more than 24 hours, and battery magnets or sharp objects, that dangerous foreign bodies are inside. If it is above the stomach, then flexible endoscopic removal is done. If it is beyond stomach, then 95% of the objects remove itself. So just wait for it to pass for around 4 to 6 days. Endoscopic removal, if it is a battery, okay, mean it is a battery, big one, and the baby is a small one. Double-sided sharp object like fish bone, toothpick, double magnets that can stick each other. Open safety pin, obviously this one, and the 5 cm long object, that is we do this kind of management. Let's watch a very quick summary table. That is, if it is the coin in the esophagus, then it is urgent and endoscopic removal would be done. If the coin is in the stomach, no symptoms is seen, so it is elective, so we will just observe. Button battery, these are emergency, because obviously this can make fistulas and perforations, so we'll do endoscopic removal very quickly. Magnets are as well urgent, especially multiple magnets, so endoscopic or surgical removal is done. Sharp object, same, urgent, remove if even if asymptomatic. Okay. Fish bone, we will do ENT scope, that is especially if it is not seen on X-ray. Okay, so let's watch some questions. The first one, that is, a 2-year-old boy is brought in the emergency department by his mother after swallowing a coin 2 hours ago. He is drooling, that is important, but breathing comfortably. The chest X-ray shows a round radio-opaque object in the upper esophagus. There is two important points, that is drooling and upper esophagus. So what will be the next step in the management? So the what obviously it is a emergency, so we will do emergency rigid endoscopy. Okay, because esophageal coins, especially in the upper esophagus, and symptoms like drooling require urgent endoscopic removal. If it is passed to stomach, then we can do something else. Okay, now a 3-year-old brought in after ingesting a button battery. His asymptomatic X-ray confirms the battery is lodged in the esophagus. What we'll do? Batteries are very, very, very dangerous, so we have these options. Obviously, urgent endoscopic removal would be done. No observation, nothing, just no monitoring, just do endoscopic removal because they can do risks of esophageal perforation and tracheoesophageal fistula that we have already started. Next is sharp foreign object, that is a 4 year a 4 year old girl swallowed a sewing needle 3 hours ago. She is a mild abdominal pain but otherwise stable. So X-ray shows needle in the stomach. Whatever happens, as it is a sharp object like needle, will do an urgent endoscopy and removal. So what is the option? Give hematics, no. Pressure, no. Emergency endoscopy, no. Laparotomy, okay. Sharp object like needle and pins require urgent removal if accessible by endoscopy, even if in asymptomatic cases due to perforation risk, okay. Now next one is a 5-year-old boy swallowed 2 magnets and he is asymptomatic. The X-ray shows both magnets in the upper abdomen. Sorry, what is the best course of action? So magnets will we don't reassure, we won't act as charcoal. It is urgent endoscopy or surgery, okay. No laxative, no observation, okay, because this can trap intestinal loops and cause pressure, necrosis, fistula or perforation. Early removal is the indication even in asymptomatic children. Fishbone in adult. 30-year-old man presents after feeling a sharp pain in the throat while eating fish. He is in mild odinophagia. Oropharyngeal exam is normal. What is the next best step? Okay, so we'll do give soft diet and discharge, no. Urgent neck X-ray, we already know where it is. ENT laryngoscopy is done, okay, because suspected fishbone with symptoms but negative exam warrants ENT evaluation with laryngoscopy. Sharp objects like bones can be missed on plain radiographs. So this is the questions. Let's do some more questions regarding the GERD, okay. Okay, a 2-month-old infant presents with the frequent regurgitation of feeds, poor weight gain, and excessive crying. There is no fever or diarrhea. Physical exam is unremarkable. What is the most likely diagnosis? Now the case is that it is under 6 months. That is, GERD means within 6 months. So it is 2-month old. So under 6 months. All right. Regurgitation of feeds, that means vomiting, so all right. Poor weight gain, so no nutrition, all right. And excessive crying. So what are the options? The other options are not, so it is GERD, okay. Next, a 4-month old, okay. I think you can see better. A 4-month-old baby presents with episodes of back arching and neck extension during or after feeding. He is irritable and has frequent regurgitation. So, obviously, what is the most likely underlying condition? It is Sandifer syndrome. That is, Sandifer syndrome means spasmodic dystonia, that means ophostotonus after feeding. Okay, the pictures I have already shown you. So obviously this one is GERD as well. It is the classic feature of Sandifer syndrome, a dystonic reaction secondary to painful GERD. Okay, now let's do the management. A 3-month-old infant baby is uncomplicated reflux, has mild regurgitation post feeding, but is thriving well with normal growth and no respiratory symptoms. Okay, so what is the thing? Start ranitidine, no, there is no option as ranitidine. Reassure and advise the feeding position change, yes, I think this one is the correct one. Switch to ammonia acidic formula, no. Refer to endoscopy, not necessary currently. Admit and monitor, so I don't think so. So it is the B option. Most cases of infant GERD improve with conservative measures like upright positioning and thickened feeds. So the what is the positioning during feeding the children? The position should be while sleep. They should be in supine position. That means naak upar, mukh opore, slightly angled at 30 degree. The baby should be like this, in 30-degree angle, supine children. And after that, in wake time, he should be in prone position. Okay, so the normal baby, just like, okay, that's it. Okay, so let's take more scenarios. A respiratory distress with NG tubing coil. Okay, a newborn baby is noted to have respiratory distress shortly after birth. He has frothy secretions in mouth, nose, and chokes with each feeding attempt. The pediatrician attempts to pass nasogastric tube, but it coils in the upper chest of X-ray. There is air in the stomach on abdominal X-ray. What is the most likely diagnosis? So obviously it is the distal, distal, no, most likely C. Yes, distal one. So what is the explanation? Frothy secretions plus NG tube coiling plus air in stomach. Classic esophageal atresia with distal tracheoesophageal fistula. Most common is the C type, that is the this one. Okay, C, option C. In case of H type tracheoesophageal fistula would have normal esophagus and NG tube would pass normally. That is this picture. NG tube will pass normally. Langenstrider causes noisy breathing, not NG tube coiling. Okay. Pure esophageal atresia would show no air in the stomach. And duodenal atresia shows double bubble sign. We'll study it just after this. Okay. Next one. A newborn is diagnosed with esophageal atresia. What other conditions should you specifically screen for in this patient? What are other conditions you can? I think Hirschsprung disease. No cardiac anomalies. Okay, so the option B is the correct answer. Factorial association, that is vertebral anal cardiac tracheoesophageal renal limb anomalies. These cardiac anomalies are most commonly seen. So this is the question's answer, this part. Okay, pyloric stenosis occurs weeks later, not known association. Hirschsprung's disease is association with Down syndrome. Meconium ileus is seen in cystic fibrosis, and diaphragmatic hernia may cause respiratory distress. Okay, next. The next question is a little bit tricky one. So a 5-year-old male is brought for frequent vomiting after feeds. So we have these two things. Most of the things are with this. He is hungry after vomiting, but otherwise seems comfortable. On exam, there is no dehydration or visible peristalsis. Growth is within normal limits. What is your most likely diagnosis? I know we will take gastroesophageal reflex, but there is an option called malnutrition. Okay, so recurrent vomiting, malnutrition, it is all right, but it may happen, may not happen. Failure to thrive, it may happen, may not be happen. Okay, So but here according to the options, I think option B is the best answer, that is gastroesophageal reflex. Because the explanation, let's look at this. In gastroesophageal reflex disorder, the vomits are effortless vomiting, non-bilious, normal growth, physiological gastroesophageal reflexes. In case of pyloric stenosis, that is this one, it presents later, around 3 to 6 weeks. Okay. And with projectile vomiting, palpable olive, and dehydration. These things are classic. Milk protein allergy causes bloody stools, eczema and irritability. Malrotation comes with bilious vomiting, and congenital adrenal hyperplasia is vomiting, usually seen in female with ambiguous genitalia and electrolyte abnormalities. So these are the important words. Next one is position independent reflux. Okay. uh, a 2-month-old baby is referred due to frequent regurgitation and feeding refusal. The mother notes symptoms worsens when the baby is lying down and improve when held upright. The baby is gaining weight normally. What is the next best step? Start omeprazole? No, obviously. We know it is GERD, obviously. So uh, the baby is gaining weight normally. So this time it is a minor or mild GERD, so we'll do simple, just wait and watch things. So perform esophageal pH monitor. Omeprazole is in case of moderate, that means second step. Perform esophageal pH monitoring, it is the third step. Trial of thickened feet and upright positioning, it is the first step. That is simple, wait and watch and change lifestyle modification. Order upper GI endoscopy, it is also third step. Switch to hydrolyzed formula immediately, it is not in this case, it is done in case of milk protein allergy, I guess. So this is the explanation. Yes, it is correct answer C. Obviously the questions are obvious, but it gives you a better insight. So first line of management is in mild uncomplicated GERD is conservative, that is positioning and feeding changes. In case of omeprazole is reserved for moderate to severe GERD and complications. pH monitoring and endoscopy, that is these two, are for refractory and complicated GERD. And hypoallergic formula, that is hydrolyzed formula, it is useful for milk protein allergy where we can see stool with blood. Okay. This one question is that a 6-month-old has recurrent episodes of wheezing and coughing, especially at night. The parents report frequent regurgitation after feeds. Growth is slightly below average. Below average. So it is a complicated case. But which of the following is the most appropriate investigation? So we know it is esophageal pH monitoring. We have two things, that is we can do a 24-hour more pH monitoring or multi-channel intraluminal impedance monitoring. Okay, so whatever. We also have endoscopy, but here is esophageal pH monitoring, the correct answer. The thing is that recurrent wheeze and regurgitation suspect GERD-induced respiratory symptoms. pH monitoring is gold standard for confirming GERD. Bronchoscopy is useful for airway anomalies, but not first line here. Chest CT is overkill. Sweat test is in case of cystic fibrosis. Okay, but it is not in here. Laryngoscopy helps in diagnosis of Sandifer's or anatomical defects. Laryngoscopy helps in what? Laryngoscopy helps in laryngomalacia, vocal cord paralysis, and subglottic stenosis. If evaluating unexplained stridor, hoarseness, choking, or chronic cough without clear reflex signs. Okay, so Sandifer means opisthotonus, tetanus like body. So here it is not happening. So the first one is obviously the pH monitoring. So this is all the questions.